Today's talk is on autopsy findings in sudden death, and Dr. Nahar Saikia, Professor Pathology, PGI Chandigarh, and Dr. Ajay Bahl, Professor Cardiology, PGI Chandigarh, are our speakers. The moderator for the session is Dr. Divyanshu Singh and myself, Dr. Nisha Modi. Webinar hosts are Dr. Anita Borges ma'am and Dr. Sumit Gujral sir. There are few reminders. In case of any connection interruption or low or no sound, video lag, kindly leave the meeting and rejoin again. Please answer the poll questions by typing in the chat box and do not send requests for annotation to the presenters. Before we start, please go through the disclaimers. There are a few more. We have our upcoming talk on 31st August, which is the slide seminar on approach to granulomatous lesion by Dr. S. Datta Gupta, St. John's Medical College, Bangalore, and Dr. Sudhir Arava, Professor, AIIMS, New Delhi, followed by the next talk on 5th September on laboratory management, including inventory management, LIS, and costing by Dr. Sujay Prasad, Newberg Anand Reference Lab, Bangalore. Now let us start. I request Dr. Uma ma'am to please share her screen.
Yeah, thank you, Nisha, for the kind introduction. So, okay. Can you see my screen?
Yes, ma'am.
Is it full screen?
Yes, ma'am.
Yeah. So the topic for today's talk is sudden death, or we now actually label it as sudden death syndrome. It's no more just sudden death. It's a huge topic, huge umbrella. So I can only give an overview in this maybe hour and a half talk, or maybe hour 15 minutes or something like that, with inputs from my colleague Dr. Ajay Bahl, who is a senior cardiologist in Department of Cardiology. And we've been working together for almost last 20 years in various types of cardiac diseases. His basic interest lies in cardiomyopathies, and so is mine. However, not to waste any time, let's start. So when we call about sudden cardiac death or sudden death syndrome, not actually cardiac death. Just a minute, I want to minimize this one. Okay. Yeah. Okay, fine. So when we describe or define sudden death syndrome, it is defined as deaths which are not preceded by significant symptoms and which excludes any violent or traumatic deaths. And the time period is within 1 hour of onset of symptoms. The WHO definition, however, says that any death occurring within 24 hours after onset of symptoms, especially when the pathologist intervene and then they say that this could be the cause of death. The difference between the WHO definition and Association for European Cardiovascular Pathology is there. And the European Cardiovascular Pathology Society says that sudden death syndrome is defined as natural death which occurs within 6 hours of beginning of symptoms in an apparently healthy subject or in the one whose disease is not severe to be fatal. Though we always, so there is a term which says that several sudden deaths are not necessarily unexpected and some unexpected deaths are not necessarily sudden. So we should remember this. Now, sudden deaths apparently which are occurring in healthy individuals is very challenging for all of us, especially for the medical examiners, even for the law enforcement officers, and even for the society. We see sometimes there are newspaper flashing all the news that a mysterious death has occurred. So we even know that in Mumbai, Sushant Singh Rajput died, and or some actress fallen off or found dead in her bathroom or whatever. So even Devi was found dead in her bathroom. So we don't know what was the cause of death. So it's very, very important to know the causative etiology and the holistic approach in investigating cause of sudden death. So in that context, it's very, very important to conduct autopsies properly. And autopsy findings, which will have, if we have some positive findings, it will have a profound effect on the lives and welfare of the family of the deceased, the law enforcement agencies, the hospital authorities, the private corporations, and also including the insurance companies. Nevertheless, many cases, autopsies may not reveal the cause of death. Now, when we classify causes of sudden death, the most important being the central nervous system and the cardiovascular, followed by the respiratory, abdominal, endocrine, some iatrogenic causes, drug overdose or something like that, some miscellaneous causes, and indeterminate. So I'll be taking each one of them one by one. So let's talk about the cardiovascular system first. The incidence of sudden death due to cardiovascular system is close to 90%. And it increases with age, so much so that there is 1 per 1,000 per year in age bracket of 35 to 40 years, 2 per 1,000 per year by 60 years, and it decreases as the age advances. So there is the importance of imaging is very, very important in post-mortem examination and classification of sudden cardiac death. Most of the times, the etiology being coronary or non-coronary causes, and coronary artery disease is the major cause of all cardiovascular deaths, ranging from 56 to 80%. So the range is very, very wide, and atherosclerotic coronary artery disease being the commonest. However, in addition to that, hypertensive patients who have left ventricular hypertrophy have a 5-fold increase in incidence of sudden cardiac death. Now, what are the important causes which can determine that this patient might have died of sudden cardiac death? So, blood cholesterol is very, very important, and hypertension, and they are the important indirect risk factors. If the systolic blood pressure measures more than 160 millimeters of mercury, it's again a direct risk factor. Overweight, obese, we all know we have lifestyle diseases, metabolic syndrome, rampant in our society. So these are direct risk factors which are responsible for sudden cardiac death. Cigarette smoking and alcohol and also drug abuse, they also have a direct relationship with SCD. When we talk about SCD in young subjects, primarily it is mostly various types of cardiomyopathies. Most commonly, it is the hypertrophic cardiomyopathies, followed by arrhythmogenic right ventricular cardiomyopathy, dilated cardiomyopathy, and myocarditis. Now, there are certain channelopathies which are very well described in the cardiology. However, pathologists are limited with the knowledge of various types of arrhythmias and channelopathies, because most of the times it's very frustrating to examine the entire conduction system, however, still not finding a biological cause of the death. But the frequent channelopathies which are responsible for sudden cardiac death include long QT syndrome, short QT syndrome, then you have Brugada syndrome, and catecholaminergic polymorphic ventricular tachycardia. And they are responsible for around 10 to 25% of sudden cardiac death in adults. In addition to that, complete AV block with idioventricular rhythm is again can be a cause of sudden cardiac death. Persistent or paroxysmal atrial fibrillation, flutter or atrial tachycardia, or paroxysmal supraventricular tachycardia is again a very important cause of cardiac death, sudden cardiac death, which the cardiologist sometimes put a note in their death performer as well. Now, when we talk about coronary artery disease, so there has to be at least more than 75% narrowing of the luminal cross section. So critical coronary stenosis has to be there to call it as a coronary artery stenosis, which has to be more than 75%. And one or major extramural coronary arteries is mostly involved in sudden cardiac death to the tune of 90%. In addition to that, there are non-sclerotic coronary artery disease, various congenital abnormalities, embolism, arthritis, dissectic aneurysm, and external compression or ostial obstruction of the coronary, which may cause sudden cardiac death. And these sometimes can occur as an aberrant anomalies or anatomical anomalies, which can be detected only at autopsy or by angiography or venography, postmortem or antemortem. In addition to that, the certain non-coronary cardiovascular diseases, which include valvular heart diseases, hypertensive heart diseases, myocarditis, that's a very important cause of sudden death, especially in young adults, ruptured aortic aneurysms, and cardiomyopathies. Someone has sent a request to me for annotation. So right now we have not reached that stage. Maybe I'll use it later. So if we classify the causes of sudden cardiac death, we have uncommon causes, the cardiomyopathy group, and the coronary atherosclerosis, which are predominant. So the cardiomyopathy group encompasses 10 to 15% cases of sudden cardiac death, the predominant being occupied by the coronary artery disease, which is majorly due to atherosclerotic process or diabetes or hypertension. Various uncommon causes which include, I just enumerated, ion channel abnormalities, valvular or congenital heart disease, which accounts only for less than 5% cases of sudden cardiac death. And this is how the sinus rhythm takes place in this. So this is the normal sinus rhythm, the ventricular tachycardia, the ventricular fibrillation, and the age systole when the clinician declares a person is dead. Now we all hear and read a lot about hypertrophic cardiomyopathies in young adults, and that's the most common cause of SCD in young adults. Hence, a molecular autopsy is fundamental for sudden cardiac death in young people. In addition to that, you can only enumerate congenital coronary artery anomalies only after autopsies, which could be either the arteries originating from the aortic sinus, they could be transposition of great arteries, or they could be left main coronary artery originating from the right sinus and maybe supplying the right heart instead of supplying the left heart. And then various other causes which can cause SCD. So there is a requirement, a need of R is that you have to incorporate genetic testing in all postmortem examinations of these deceased. Now, if we see the world data, we do not have a registry in India as of now, as of today, about the sudden cardiac death. If we compare the registries of Italian population, American military recruits, or Australian population and the athletic field, so we see that most of the population have got cardiomyopathy as the biggest chunk of cause as a sudden cardiac death. However, if we see the American military, there you also have anomalies of the coronaries and myocarditis as a major chunk. Similarly, in the Australian SCD registry, structurally normal heart along with cardiomyopathy and myocarditis becomes the most important cause of sudden cardiac death in these patients. If we classify sudden cardiac death in young athletes, so most commonly that is to the tune of 36%, it is hypertrophic cardiomyopathy, followed by coronary artery anomalies and myocarditis. So myocarditis can be caused by any virus, irrespective of the type of virus. Even the influenza virus can cause myocarditis. So we should not just surpass a viral illness if a patient is complaining of even slightest chest discomfort. So you should rule out a possibility of myocarditis in this, especially in the young patients. In addition to that, in today's scenario, when we talk about sedentary or mild activity life disease, so we know that most of the deaths occur in early morning, either in the bed or while asleep. Others happen at the home and followed by mild activity, that is playing baseball or some running, mild running or walking, swimming, and sometimes other sports and some medical procedures also. So they can also be causes of sudden cardiac death in young adults or even in later age groups. Now let me take you to the journey of these sudden cardiac death autopsy findings, which was present in our cohort of patients at PGI Chandigarh. Now this was a 49-year-old male and patient had a clinical diagnosis of hypertrophic cardiomyopathy. Now you must be wondering that patient is 49-year-old male. That is little odd for hypertrophic cardiomyopathy because these patients usually do not survive that long. However, this patient had a presentation of congestive heart failure. So he had genotypically hypertrophic cardiomyopathy, but phenotypically he was presenting with dilated cardiomyopathy. And there was serous effusion in the pericardial cavity as well as peritoneal cavity. Now, if you examine the heart was overweight. It weighed around 400 grams. The fat was slightly increased on the anterior surface. Now, if you see, this is pale yellowish thing is the fat on the epicardial surface, and you have a bulge of the left side of the heart. This is the left auricle, which is crenellated. It has this crenellation. So I call it as like a lace-like pattern, when you put a lace on your dresses. So it has this kind of crenellations. That's how you identify the left auricle. So that's normal. It's slightly discolored though. So whenever you have an auricular discoloration, it feels firm. Do examine it, open it nicely to rule out any thrombus. The right auricular, however, is broad-based. It's much more triangle and it looks normal in color compared to the left side. Now we cut open the heart. So this is the left side of the heart. How do you say this is left side? You can see the left atrium. This is the smooth part of the endocardium. Now the endocardium is thickest in the left atrium. The valves are also very, very thick. They are opaque. Normally the valves should not be opaque. They should be very, very translucent. But if you see the wall thickness of the left ventricle, it's measuring around 2 centimeters. So I put up a scale for all of you to see that it's measuring 2 centimeters. The normal thickness of the left ventricle is not more than 1.5 centimeters. And the left ventricle appears very bulky with a narrowed cavity. The cavity size is really reduced. And this is the outflow tract. Why this is outflow tract? You can see the aorta here, the aortic valve. And again, you can appreciate the ventricular hypertrophy. Now, point to note here is there is no myocardial discoloration. Now, this is the cross LV. This is very important when you're talking about left ventricular hypertrophy because that can occur in almost all cases of hypertensive heart disease, which is staying for more than 5 to 7 years. So if you see, this is the normal. So normally the right ventricular cavity is slightly crescent shaped, whereas the left ventricular cavity is round. This is the interventricular septum, and this is the free wall of the left ventricle. Why I'm taking time on this slide is because I shall be showing you these slices in subsequent case demonstration. So you should know this is the free wall, anterolateral wall, the septal wall, the posterior lateral wall, and the right ventricle. If you examine a case of left ventricular hypertrophy due to hypertension, this is what it looks like. So you will have a concentric left ventricular hypertrophy with narrowing of the lumen of the left ventricle. However, in case of hypertrophic cardiomyopathy, if you see the free wall ventricular wall thickness of the left ventricle is much less than the ventricular septum. Now, this is what classifies and qualifies for hypertrophic cardiomyopathy. So the wall thickness has to be minimum of 13 millimeters. Remember the unlucky 13? So even on echocardiography, if the wall thickness is more than 13 millimeters, it is quite diagnostic and suggestive of hypertrophic cardiomyopathy. This actually sectioning is not preferred for hypertrophic cardiomyopathy, as we all say that the septal hypertrophy is usually irregular in hypertrophic cardiomyopathy. So one should go for the 4-chamber dissection. So this is a 4-chamber dissection. The right side, the left side, and the left ventricular cavity is maximally narrowed due to irregular septal hypertrophy. It's much more broader in the upper end compared to the close to the apex. And it is usually inverted S in shape. And here it is changed its shape and size. So it's very, very irregularly hypertrophic along with diffuse left ventricular hypertrophy of the free wall as well. In addition, there are these pale areas. Now I'll come to that thing why are these pale areas. Now when I was talking about the 4-chamber view, now this is the same case which I showed you earlier. So because this was opened by the inflow-outflow tract method, so it's difficult to do a 4-chamber view in this case. However, if you see the apical slice, so you see marked hypertrophy of the left ventricle, especially of the septum. In addition, there are these pale gray areas running in between the myocardium. Here also, if you see on the apical slices, and on doing the 4-chamber view, this is the right side and the left side, you see the septum is markedly thickened, suggesting that it is septal hypertrophy, and which again measure 2 centimeters in thickness. Now let's see, the microscopy. This is what the low power microphotograph of the hypertrophic cardiomyopathy looks like. So if you remember your histology knowledge, the fibers are just crisscrossing each other. So this is called as myofiber disarray or a sarcomatous pattern with interstitial fibrosis. So these pale areas represent the fibrotic areas and the pink areas are all the myocytes which are crisscrossing each other. And this is on higher magnification to appreciate this myofiber disarray and isonucleosis. So there is significant amount of myocardial hypertrophy with profuse interstitial fibrosis highlighted on Mason stain as this deep blue color. So if you have this mental picture in mind, sometimes you get endomyocardial biopsies where it is difficult to say that it is myofiber disarray. But if you see that crisscrossing, then it is quite suggestive of hypertrophic cardiomyopathy. And this is the Orsine stain which highlights the striations very well. And if you see closely, some of the striations are broken. So that means the intercalated discs in between are the disrupted in this heart. And of course, we did electron microscopic examination. Now, this is what the normal looks like. I showed this so that you can compare with the case. If you see, this is the Z disc. This is your intercalated disc, the dark band, right? This is your A band and the I band. Now, if you compare this from this present case, you see there is increase in number of mitochondria. Now, because it is an autopsy tissue, the mitochondrial details are not very well preserved. There is presence of Z disc normally. However, the intercalated discs are disrupted. Now, if you see this intercalated disc, this is quite disrupted. So there is fragmentation of the intercalated disc. There is myofiber disarray. If you see these, these fibers are disrupted, and you have abundance of mitochondria in the interstitium of the myocardium. This is another photograph to appreciate the abundance of mitochondria with myofibrillar degeneration of the myofibers. So that is the finding which you see on the ultrastructural examination of hypertrophic cardiomyopathy. Now, if we examine the cross section of the left ventricle, this is how it looks like. So you see severe myocyte hypertrophy with anisonucleosis, and each myocyte is encircled by this fibrotic process. Now, someone might say, why it is not amyloid? So amyloid also may have some positivity for Masons, which is pale blue. However, if you see here, the myocytes are hypertrophic, which will not happen in amyloid. In amyloid, the myocytes will undergo either they are normal or they undergo atrophy. In addition to that, another clue which you get by examining the heart is thickening of the intramural vessels. That's very, very important and very sensitive soft pointer to diagnose hypertrophic cardiomyopathy. And if I show you the panel, this is the higher magnification, you see this, you have aneurysmal outpouchings, fibrointimal thickening of the arteries, and if you see the elastic stain, so you can clearly see there is reduplication of the elastica with fibrointimal proliferation and causing narrowing of the lumen. And just in the vicinity of this vessel, you have replacement fibrosis. When we say replacement fibrosis, we mean that there is no preservation of the myocytes in that area. So if you see at the right corner, lower bottom, you see this prominent replaced myocyte fibers by the fibrotic process. Now, since you have seen so much of extensive of fibrosis, you have to examine the coronaries in irrespective of any etiology. And the coronaries essentially showed normal lumen. All the coronaries, this is the right, left, the left marginal and the circlant, they were all normal. And this is the right side inflow. Why this is right inflow? Because you can see this prominent musculae pectinate and normal endocardium compared to the left-sided endocardium of the left atrium, which was markedly thickened. And right outflow also shows normal valves and pulmonary artery with some element of right ventricular hypertrophy because there is significant LVH. So back pressure is occurring to the lungs and causing a right ventricular hypertrophy later. Now let's come to, so that was about the hypertrophic cardiomyopathy, the histology and the gross examination. Now this is another case. So I don't know whether this can be interactive or not. Dr. Ajay, are you listening?
Yes, yes.
So can you give any comments from the clinical aspect in cases of hypertrophic cardiomyopathy? Any inputs from the clinical side?
I have.
You
a
remember this case was discussed in one of the staff CPCs, our Wednesday CPCs here only, and it was presented in one of the conferences also, and it did have mutation. It was observed. However, that mutation was not found in the myosin heavy chain and myosin binding protein. So he behaved like a DCM, but genotypically he had HCM.
Yes, that's true. I mean, in hypertrophic cardiomyopathy, there are various presentations. So it can be with obstruction, without obstruction. So non-obstructive and obstructive. In addition to that, it can go into a dilated phase. Around 3 to 5% behave like later go into a dilated cardiomyopathy.
That's burnt out cases.
LV dysfunction and they have poor LV function. Another phenotype that may be associated with sudden death is an apical aneurysm, a mid-cavity obstruction with an apical aneurysm. And then some have a very severe diastolic dysfunction. So severe diastolic dysfunction is restrictive physiology. So restrictive physiology is just a severe diastolic. So these are the various variants, but every single variant of hypertrophic cardiomyopathy is associated with risk of sudden death.
And the case I showed had obstructive type of hypertrophic cardiomyopathy. It was not non-obstructive because mostly it obstructs. That's why sometimes you get surgical samples of myomectomy because they want to release the obstruction. So they remove the part of the muscle, the left inflow tract to release that obstruction. Now let's come to the second case. This was a 60-year-old male and clinically a patient died suddenly. There was a sudden cardiac death and there was a suspicion of myocardial infarction and patient was a known case of type 2 diabetes and essential hypertension. So we have both the risk factors here. And it was a partial autopsy. Patient was moderately built and some amount of hemorrhagic fluid was seen in the pericardial. So this is a lot of fluid in the pericardial cavity. Normally, you will not see more than 15 to 30 ml. That's the range in pericardial cavity. If you see 400 ml, that means it will cause cardiac tamponade. Now, this is what the heart looked like grossly. So if you compare the previous heart, here the heart is becoming slightly rectangular. You know, the fat is preserved, the right auricular is fine, so is the left one, but the heart appears to be slightly oblong or rectangular. And the apex of the heart appears slightly thinned out. It's completely blunt. Normally it should be pointed out. And of course, it weighed 410 grams, which is much higher than the normal. The range which we take in autopsy for females is around 200 to 250 and in males is 250 to 300. This is according to the Indian standard. However, in Western standard, it is 300 to 350 in males and 250 to 300 in females. Now let's see what happened to the apex. Why was it like that? So if you just keep this picture in mind. So this apex is very, very thinned out and blunt, right? So this is how the apex looked like when we saw it closely. So there was a large area of hemorrhagic discoloration and there was dilatation and thinning out of the ventricular wall, which was causing aneurysmal dilatation of this left ventricular wall. And this was happening in the left anterior lateral wall. And the cut surface of the same was very, very hemorrhagic, bordered by these dark hemorrhagic areas. You see, this is the septal portion, right? And this is your right ventricle, and this is the cut surface. So anterior lateral wall is involved by this hemorrhagic process, which is measuring, say, around 3 into 3 centimeters in configuration. Now let's see the outflow tract. This is the inflow and this is the inflow of the right side. So this is, if you see the left ventricle wall, again you can see the transmural hemorrhagic area. This is a nice hemorrhagic area which is involving the anterolateral wall of the left ventricle and causing aneurysmal dilatation and almost causing rupture. That was the reason of hemorrhagic pericardial effusion in this case. However, the right side, the right atrium and the auricle are unremarkable. There is no thrombus sitting in the right side. And this is what the microscopy looked like. So on the left side, the myocardium is relatively preserved. I would not say preserved, but on the right side, it is completely hemorrhagic necrosis. Lot of interstitial edema. And if you see it on close examination, this is the hemorrhagic necrotic area. And next to that, you can see these fibers are looking bright pink. So it's called as hypereosinophilia. And at the periphery, in the subepicardial location, why I'm saying subepicardial? Because you can see fat here. All the myocytes are vacuolated. So they are all degenerated. So there is necrosis. And this is on further higher magnification to appreciate this hypereosinophilia of the myocytes, losing their nuclei and lot of fragmentation of the myocytes along with some neutrophilic infiltrate here and there. This is another view to appreciate this neutrophilic infiltrate with extensive hemorrhage and loss of myocytes causing myonecrosis. So this is a case of transmural hemorrhagic acute myocardial infarction. And of course, when you see such a case, you have to examine the coronaries. And when we examined the coronaries, it did not show significant occlusion. However, the LAD did show some amount of occlusion in the middle of it, right? So we know that left coronary immediately divides after its origin into LAD and left circumflex. So the LAD was showing nearly 50% occlusion of its lumina due to atherosclerosis. So you can see the calcified plaque here. Although the plaque is stable here, but it did cause myocardial infarction. And because this patient was a known case of diabetes, the kidneys revealed KW lesion. We all know this, nodular hyalinosis with patent peripheral capillary loops, and the arteries in the kidney also reveal arteriosclerosis. So this was a case of transmural myocardial infarction involving posterior inferior wall, which is not very common. The right coronary thrombosis was present, along with there was triple coronary artery disease, triple vessel. When I say triple vessel, all the three arteries have to show at least 75% of the narrowing. Microscopically, it may not show you 75% of the narrowing because sometimes there is dislodging of the atheromas or there is ulcer, so it gets dislodged. So you have to see on gross examination. And of course, patient also had diabetic nephropathy stage 3. Now let's see another case. So this was a 40-year-old male. He had refractory cardiogenic shock, and again he was suspected to have anterior wall MI. So that was posterior inferior wall, which involves mostly the right coronary artery and left circumflex. However, this patient had undergone PCI. So temporary pacemaker was given in the LAD. In addition, patient also had a history of old CV. So this is the heart in the fresh state, and this is the pericardial reflection. If you see the heart here, again, it is looking very, very globular, little bit of rectangular or globular, so recto-oblong shape. So this is very, very irregular to see. You know, it's not a smooth pericardial surface. So that tells you that there has been some evidence of pericarditis, and it's very, very red in color. Normally, it's not so red, right? And this is how it looks like after fixation. So you can see fresh fibrinous tracts, and again the apex is showing you these hemorrhagic areas with almost rupture at the apex here and also here, and lot of pericarditis seen over the anterior surface of the heart. Another photograph, now this is again dissected through the 4-chamber method. Now this is 4-chamber dissection, transmural hemorrhagic necrosis involving both the septum, the free wall, posterior inferior wall, as well as the inferior lateral wall. Now this is a very, very extreme and rare situation when you are having involvement of the left side as well as right side, and also the inferior wall and base of the heart and the apex here. You can see the marked thinning of the apex here, almost going to the edge, you see here. So almost ready to rupture, causing pericardial deafness. This is after the fixation. This is how you see the heart. So transmural hemorrhagic necrosis, more so in the subendocardial location, also involving the papillary muscle here and reaching up to the apex even here. And the free wall is much more involved compared to the septal wall. Now, what could be the etiology? In spite of patients received timely treatment and patient post temporary pacemaker, he died. Why did we lose him? This is another picture to appreciate this thrombi, transmural necrosis. You see here, this is how it looks like. And there are mural thrombi in the ventricular cavity. Normally, it should be empty and involvement of the papillary muscles. Whereas compared to that, the right ventricular cavity is normal. Okay. This is what the microscopy showed. So you have evidence of fibrinous pericarditis. This is the pericardial fat. And you can see just a thin rim of myocardium is seen here. Rest all of the myocardium was showing hemorrhagic necrosis right here. And you also show presence of mural thrombi. This is the MSB stain, which stains the fibrin red in color along with blue admixture. So telling us that there was a mixture of old as well as fresh fibrin. Now let's see on high power. I showed you the previous case where there was hypereosinophilia. Here the hypereosinophilia was not very prominent. However, the fibers look very, very wavy, like sea waves. Lot of interstitial edema. Normally, you should not see this much of interstitial edema and myonecrosis. Another areas, appreciating this waviness of fibers, hypereosinophilia and dense neutrophil rich infiltrate in the interstitium causing myonecrosis. And again, myocyte vacuolization due to myonecrosis. So this was again a case of acute MI. Now, if we go about the time zone of MI, in usually less than 24 hours, you may not see significant infiltration by insect. However, you would see wavy fibers, you would see hypereosinophilia, you would see marked interstitial edema and marked interstitial vascular congestion. So these are the features which should take you, which should make you think that you might be dealing with a case of myocardial infarction. And our present case belongs to the category of 30 minutes to 4 hours. However, in addition, there was neutrophilic infiltrate. So how do we explain that? Let's see. How do we explain that? So these are the coronaries. And if you see, the circumflex essentially looks normal. However, RCA is clearly totally occluded right here. And there is a thrombus sitting here, which could be examined on cross examination. See here, there's a thrombus sitting on the right coronary artery. And this was the cause of involvement of the septum, not the free wall. So again, hemorrhagic necrosis transmurally. And this is what the microscopy showed. So you have presence of thrombus in the right coronary artery. This is the elastic stain. Elastica is maintained. However, you have a presence of fibrin thrombi with narrowing of the lumen. So this was the cause of infarction of the right side. In addition to that, if we see another photograph, there are multiple pinpoint to pinhead size hemorrhagic spots. Why are these occurring? So when we saw that, and presence of mural thrombi could be confirmed by both HME and Marshall scarlet blue stain, and this is the EVG to appreciate this endothelium and thrombi in the lumen. This is what these pinpoint hemorrhages and those hemorrhagic areas look like. So the fibers are displaced by this RBCs. So you have diffuse hemorrhage. This usually does not happen in myocardial infarction. You will have edema, you will have interstitial vascular congestion, neutrophilic infiltrate, but not this type of necrosis. So why this happened? So this is another view. So you have diffuse interstitial hemorrhage highlighted by MSB, and this is the nasons telling you that there is no fibrosis. This happens in reperfusion injury. So this patient had two things. He had acute myocardial infarction of the LAD territory, which involved the anterolateral wall, along with reperfusion injury, which involved the left ventricle, the septum, as well as the right ventricle, which resulted in presence of mural thrombi. So this was a case of AMI with ischemia reperfusion injury post PCI, right? And of course, he had triple vessel coronary artery disease with complicated atherosclerosis. And the old infarct was a thromboembolic infarct, which was present in the right frontoparietal region due to involvement of the MCA territory and the right thalamic region. So let's come to another case. This patient is, again, now you see the sequence of events. Most of our patients are young adults, 40, 49, 42, something like that. So this was also a 40-year-old male. Clinically, patient had refractory ventricular tachycardia, also had febrile illness. The patient was query HIV positive. Nobody was sure. Does that ring a bell? HIV positive, autopsy has been done. Probably you will all think of disseminated infections, right? But possibly may not be because it was doubtful, but maybe, right? But if you see the heart, now remember the previous hearts. This heart has maintained its shape, essentially. There is a white patch on the anterior aspect. This is a healed pericarditis, right? Which we usually call as soldier's patch. And you have some amount of fibrinous pericarditis on the left side of the heart. This is the right border and this is the left border. Okay. Now let's see on the closer examination. This is the right side of the heart, the right inflow, the right atrium, auricle, and the right ventricle essentially look normal. However, the right ventricle was slightly hypertrophic, borderline hypertrophic. It measured around 4 millimeters. The upper limit for right ventricular hypertrophy is 5 millimeters. So there is right ventricular hypertrophy. So what could be the cause? Now you have to think. RVH causes. And also patient had left ventricular hypertrophy. It measured around 2 centimeters. But the myocardium was looking more pale compared to the hemorrhagic discoloration which I showed earlier. You see here, papillary muscle also seemed to be quite hypertrophic. The chordae seems to be thin and so are the valves. So what happened? Now if you see here, in this area there was a slight patch of discoloration. Only this area and at the apex, little bit of discoloration. If you see on the microscopy, you don't see much of the findings. You just see little bit of interstitial fibers. This is described as interstitial. I showed you the replacement fibrosis in HCM. Now this is what is described as mild degree of interstitial fibrosis. Not much of myofiber disarray or myocyte hypertrophy or atrophy or any congestion or edema. However, on a higher magnification, this is what we found. We had lymphocytic infiltrate into the myocardium causing myonecrosis focally. You see here, multiple foci of myonecrosis were seen. And on a further higher magnification, this is the myonecrosis, presence of lymphocytic infiltrate within the myocardium. So this qualifies for myocarditis. So this patient had myocarditis. And of course, whenever you see myocarditis, you start to subtype it. So predominantly, you'll expect CD3 cells. Some histocytic cells, maybe their CD20 is usually negative. So if CD68 is abundance, then you say it's resolving or resolved myocarditis. If there's an admixture, it is in the subacute phase of myocarditis. Now, diagnosis of myocarditis is very, very tricky because it's a patchy focal lesion. You may not see even in a biopsy, and sometimes even after autopsy, you may not be seeing it. So you have to have multiple sections. So we don't follow the Dallas criteria these days. We follow the Marburg criteria to classify and diagnose myocarditis, where you have to have histomorphology, immunohistochemistry for identification and detection of the inflammatory cells. And of course, you have to do PCR to rule out any viral etiology. And if at all you are lucky, you may do an endomyocardial biopsy if it is indicated. You cannot do endomyocardial biopsy just like that. And of course, many times we see the presence of myocarditis at autopsy. So we know the different phases of myocarditis: acute, subacute, and chronic. And this patient, we were dealing with the subacute myocarditis, which is a phase of T cell activation with viral clearance. If this phase stays, there's an autoimmune phenomenon which occurs, and that leads on to the dilated cardiomyopathy or inflammatory cardiomyopathy. Now, let me show you another case. Again, a young male, right? 38 is pretty young, I guess so. Patient had clinical diagnosis of acute febrile illness. with thrombocytopenia, and the clinicians were suspecting leptospirosis versus dengue. There was some pleural effusion. The pericardial cavity was, however, normal. As you see, the weight is slightly on the higher side, but the anterior surface of the heart looks normal. So you might be thinking, leptospirosis, dengue, what will the heart show? So remember, in leptospirosis, if it is dengue hemorrhagic fever, you probably would see hemorrhages in the myocardium. And if it is leptospirosis, it may show you myocarditis. And this is the left inflow. How do you identify left and right? You see smooth endocardium. No musculae pectinate in the left auricle, right? This is how you identify wider chamber and thick papillary muscles. Whereas this is the outflow tract, so thick papillary muscle here. The myocardium is not looking like any discoloration. Some whitish areas could be seen on the apical region. There could be some ischemic scars, right? And this is what the microscopy showed. Diffuse myocarditis, lot of interstitial edema and lot of interstitial inflammation. And if you see closely, you see here, most of the cells are lymphocytes admixed with plasma cells with lot of edema and myonecrosis focally, along with RBC extravasation. Further high magnification to appreciate the nature of the cells, lymphoid cells as well as plasma cells. So remember that most of the times in myocarditis, you will see lymphocytes. However, you can see eosinophils or neutrophils. Neutrophils you see when there is a bacterial infection or some kind of disseminated infection, and eosinophils usually you see in Loftus syndrome, right? Another case who had a clinical diagnosis, this was again a young male. He had a clinical diagnosis of acute necrotizing pancreatitis with lung injury and kidney injury. And this is what the heart looked like. And to my surprise, patient also had hepatitis. And when we did the PCR for viral etiology, it turned out to be positive for Coxsackie B virus. And this is how the hyper looked like. Okay, so remember, a minimum of 5 sections are required. Minimum, I'm saying. Including the septum, the free wall of both left ventricle wall as well as right ventricle, inflow tract of the left ventricle, to rule out a possibility of myocarditis. Otherwise, you may miss it. And this is what I want to show. Sometimes it can be very, very focal and subtle. But you should do Mason's trichome saying. So Mason's trichome will highlight this necrotic myocyte necrosis. Sometimes the inflammation is not very prominent, but the myocyte will show these degenerative changes. Okay. And of course, if you're lucky, you can go for immunohistochemistry, where you can do CD3 or CD68. Okay. So yeah, this case also had inflammation around the veins. This is the coronary vein and also into the pericardium. And this is the higher magnification. So patient also had pericarditis, though it was not visible grossly. Now let's come to another case. This was a very interesting case, and recently we had presented this case in one of our CPCs in PGI. So again, adult male, heart was around 380 grams, slightly overweight. There's some. Now, if you see the fat is mainly seen in the areas where the coronaries are running. This is the territory of LAD artery, and this is the territory of left circumference. So shape is essentially maintained with some apex blunting. However, if you see the right inflow, this is the superior vena cava. You can see kind of a polypoidal or a plaque-like lesion here. These are musculae pectinity, and this is the right atrium, right? So this, you identify right atrium by presence of this rough part and the smooth part, and this is crista supraterminalis. Okay. So let's see the left side of the heart. Now this is the left inflow. Now if you compare the previous hearts from this one, you can see these large verrucous lesions which are hanging on to the atrial aspect of the valve. But there is no commissural fusion. However, they are also present on the commissure, so maybe you will not be able to comment on the commissural fusion. So commissural fusion you see in cases of rheumatic heart disease. But these are large verrucous hemorrhagic necrotic lesions sitting on the valve surface, multiple of them, many of them. And just beneath this, you have a myocardial necrosis. Seen that. And this is what the section from that verrucous lesion looked like. And they were also present in the aortic valve. So you saw the plaque-like or verrucous lesion involving the superior vena cava, the mitral valve, as well as the aortic valve. But there is no valvular fusion. So possibility of rheumatic heart disease is less likely. However, being an endemic country, India being a tropical country, we need to keep that possibility that there might be an element of mitral regurgitation, if not stenosis. In addition, you had some small subendocardial hemorrhages. And this is the section from that verrucous lesion, which shows fibrin and these blue areas. So pink areas and blue areas. And blue areas are nothing but gram-positive cocci. So it was loaded with gram-positive cocci. They are all vegetations. And this is a Mason stain showing no fibrosis, but a lot of gram-positive cocci. Now, this is the section taken from the superior vena cava. So there was a presence of mural thrombus and a vegetation there also. So lots of fibrin, lots of neutrophils and bacterial colonies and the wall here. This was due to the presence of central venous line. So that is very important in patients who have been put on central venous line. And if you see on a closer examination, lots of nuclear debris, some neutrophils, and you have seen this elongated cells, some of them, which have this kind of wavy chromatin, right? This was not expected in this case because there was no commissural fusion, no chordate thickening, no shortening of chordate, and some of them also showing this kind of owl-eye appearance. And if you see on a closer look, the less involved areas also showed similar caterpillar-like chromatin, owl-eye appearance like this, and the myocardium also shows evidence of myocarditis with formation of air-shaft nodules. So this patient had active rheumatic pancarditis. Not only myocardium was involved, the involvement of valve and pericardium was also present. And this is a nice caterpillar cell, or the other name for this is Enitzkov cells. And if you cut them in the cross section, it shows an owl-eye appearance, right? Of course, there is an element of pericarditis, inflammatory component is seen here, right? In addition to that, there were certain pale areas which were seen only on microscopy, dissecting through the myocardium. This is moderate degree of interstitial fibrosis. And one of the coronaries did show luminal occlusion with areas of calcification. So patient had repeated showers of ischemia, which resulted in this scar formation. However, it is not qualifying for myocardial infarction. The definition of myocardial infarction, old or fresh, is that it has to involve 1 square millimeter area, both grossly and microscopically, and it has to be territorial in distribution, whether it is atherosclerotic or non-atherosclerotic coronary artery disease, depending on the etiology, right? So this patient had subacute active rheumatic heart disease, which was causing pancarditis. In addition, there was infective endocarditis of mitral and aortic valve, along with infective embolization to systemic organs. In addition to that, I must say that this patient had aortic dissection, which was being treated. He did not die of aortic dissection, but he died of infective endocarditis. Now, you should remember that when you're talking of sudden cardiac death, don't forget commotio cordis. Now, commotio cordis is basically a sudden hit on the chest. So it could be usually while playing, that is playing baseball, softball, or soft hockey or whatever. And suddenly it causes cardiac arrest. So you may not find any pathology on autopsy. So that's where the importance lies. As I said in the beginning, that autopsy may not give you 100% answers. However, it may be able to resolve at least 90 to 95% of cases if we include the molecular workup in these patients, right? So what is the importance? When we are doing autopsy, what should you do? There is no ideal sample. However, if there is pericardial effusion, you should take sample for biochemical markers. You can assess cardiac troponin I in the pericardial fluid, and also you can see ratio of the troponin with other markers in the pericardial fluid and serum. You can do immunohistochemistry or Western blot in the myocardial specimens for fatal sudden cardiac deaths. And of course, we can do various inflammatory mediator cytokines, naming all these in the pericardial fluid or even in the peripheral vein sample. Now, remember that you have to take minimum of 5 sections from the heart at autopsy and preserve the splenic tissue. Because why splenic tissue? Because it is rich in cells. So it will be very, very useful for DNA extraction and genetic analysis. Right here. So this is for the sudden cardiac death or all sudden death actually. Because as I said, 90% of the deaths are usually sudden cardiac death. Right? So when we say sudden death syndrome, 90% of the times it is sudden cardiac death. Right? So that covers sudden cardiac death. Now, before I move on to the respiratory system, I would like Dr. Ajay to give his inputs.
Thank you, Dr. Uma. That was a great presentation. Now, can I just share my screen, please. I think you'll have to
I'll
stop your screen share. Yes, please.
Is that okay? Can you?
You'll have to show. Let me just see. Yes, okay, it's allowing me to share. Just a second. Oh no, you'll have to stop sharing before I can.
Just a second. It's not showing me.
Somewhere on the top probably. Stop sharing.
Yeah.
Stop. Yeah, that's fine.
Yeah, I did that.
Thank you. Yes.
Is that okay?
Yes, ma'am.
Yes.
Yeah. Okay.
Thank you. Good evening, everybody. So I will basically be just showing the importance of the molecular testing, or rather than using the word molecular testing, genotyping. Basically finding the correct mutation. That is more important. And it is very important in a patient who's died suddenly, especially in young individuals. We know that 30 to 40% of cases of SCD in young will remain unexplained despite a complete autopsy. Cardiac gene mutations have been identified in different series in around 1/4 of patients who have had sudden death, young patients. And clinical diagnosis of inherited cardiovascular disease is identified in 13% of relatives. So this is what is important, that whatever autopsy that we do, it should benefit the relatives. So that is why probably molecular or genotyping is extremely important. And it is important because sudden cardiac death may be the first presentation in asymptomatic individuals. Therefore, identifying relatives who are asymptomatic is also important. So why is the diagnosis important? Because if we are able to reach a diagnosis, we are able to screen family members for risk of sudden cardiac death. And over here, it's not just a clinical diagnosis. The genotype is also important because we know that cardiomyopathies and arrhythmic disorders are largely Mendelian disorders, most commonly inherited in an autosomal dominant pattern. If we look at the American Heart Association classification of cardiomyopathies, we can see that genetic, mixed, and acquired. And if we see, most of the cardiomyopathies and arrhythmic disorders are pure genetic disorders. Hypertrophic cardiomyopathy, ARVC, left ventricular non-compaction, some glycogen storage disorders, and the arrhythmic disorders are all inherited by and large in an autosomal dominant. There are some cardiomyopathies like dilated cardiomyopathy and restrictive cardiomyopathies, which are inherited as well as acquired. So around 1/4 of all dilated cardiomyopathies are actually inherited disorders, and approximately half of all restrictive cardiomyopathies are inherited disorders in an autosomal dominant pattern. And if we see the list of acquired, that means the ones which do not have a genetic component or a strong genetic component, the numbers are relatively limited. So when we are looking at sudden death in young individuals, we are largely looking at autosomal dominant disorders. So why is the diagnosis important? Supposing we do not carry out an autopsy in an individual who has had a sudden death, then we will not. How do we screen the first degree relatives? Because there is a lot of anxiety that is this risk there in the relatives also. So how do you screen? You can't really screen them for a particular disease. So you generally do a screening which will include a ECG, a echo, or a TMT, and we may not be able to reach a specific diagnosis. So this is a very important opportunity loss for the family, where other family members, a sudden death can be prevented in other family members. If we carry out an autopsy, we may have a non-specific findings, or the autopsy may be normal, or we may reach a specific diagnosis. In both these conditions, we must do genotyping. Even if we reach a specific diagnosis, let us say hypertrophic cardiomyopathy, genotyping is still important. So, and why is it important? Because there are two ways we can screen the relatives. One is doing a genotyping of the relative, and the other is to do a clinical screening. Supposing we do not have the mutation, the only option is to do a clinical screening of relative cardiomyopathies. So clinical screening involves ECG, echo, and may involve a cardiac MRI. But the problem over here is that the screening is carried out indirectly. So the recommendation is that you screen every 1 to 2 years from between the age of 12 to 18 years at the time of the growth spurt, and every 3 to years thereafter lifelong. And the reason for that is that most of these disorders have an age-related penetrance. So it may not manifest at the age, it may manifest at the age of 50. So clinical screening is a cumbersome and a lifelong process. However, if we are able to, we can never tell, based on a clinical screening, we can never tell an individual that he will not develop disease in the future. We can just tell him, right now you do not carry the disease, you're not at risk, but at future, whether you develop it or not, we cannot do that without genotyping based on clinical screening. And I'll just show you one of our studies where we screened a large number of troponin I mutation carriers, and what we found was that there is an age-related penetrance. So you can see that the diseases, you have asymptomatic carriers or normal carriers, phenotypically normal carriers who continue till the age of 50. By the time they reach the age of 70, there is 100% penetrance. So beyond the age of 60 to 70 years, the penetrance is very high. Otherwise, these individuals can keep developing the disease as they continue to age. So clinical screening, we cannot tell an individual that he will not develop a disease in future. And that is why genotyping is important. Because if we identify a pathogenic or a likely pathogenic variant, once we identify it in the family, we can screen the relative by a very simple Sanger sequencing. And if this individual does not carry the mutation, no further follow-up is needed. Therefore, even if a specific condition like a hypertrophic cardiomyopathy or dilated cardiomyopathy is diagnosed, only clinical screening is possible if the mutation is not identified. We must try to do a genotyping of all patients of sudden cardiac death, especially young individuals, less than 50 to 55 years of age. Genotyping is important, even if the morphological diagnosis is established, to help in the family screening. So identification of the mutation is important. Simple diagnosis like a hypertrophic cardiomyopathy is not enough. If genotyping is not carried out at the time of autopsy, opportunity for the family is lost. So we all know what are the genes which are involved in these cardiomyopathies. They are largely sarcomeric and cytoskeletal genes. So how should we carry out the screening? What is the genotyping strategy that we can use? So whole genome sequencing is usually not carried out in a clinical setting. This is more of a research setting. So we have two options. One is a panel and the other is a whole exome sequencing. Both are good, reliable options. And nowadays the cost of sequencing has really come down. So panels are relatively more focused and they have a higher sensitivity. The disadvantage of panels is that you will not look at genes which do not cause cardiomyopathy. That means you are not looking at less common mutations which are there, or genes which are not really known to cause cardiomyopathy. They will not be screened. The other option is to carry out a whole exome sequencing. However, there's very little to choose between panels and whole exome sequencing. So what is the problem of next generation sequencing? The problem of next generation sequencing is it's very easy to sequence nowadays. Our ability to identify sequence variations has far outstripped our ability to interpret the significance. The problem that we have in next generation sequencing is we'll get a lot of sequence variations and we will not really know the significance, because there are so many variations between two different individuals and between different populations. So this is where we are stuck. Significance of sequence variations in disease-causing genes for a large number. We know the significant number, we still do not know the significance. Sorry. And why is, and just to highlight that what are the types of sequence variations that you get in cardiomyopathy? You get thousands of sequence variations, and this is because of a large number of founders. That means de novo mutations very frequently occur and they are spread across multiple genes. So there are thousands of variations that cause cardiomyopathies. And what is a founder? A founder is an individual with de novo mutations. The parents are wild type, that means they do not carry the mutation. This individual has a 50% chance of transmitting the mutation to his offspring. If the founder is recent, that means just a few generations back, only a small number of carriers, maybe a family or an individual or maybe 5-10 individuals will be affected or will be known to carry this particular sequence variation. And in this situation, very often we will not know the significance of this sequence variation. Whereas a sequence variation that occurs a long time back, like this sequence variation in myosin binding protein C, occurred around 33,000 years back. So this is so common. It's prevalent in 4% of individuals. So sequence variation that is common, we know what is the pathology it causes, what are the disease that it is going to cause, what is the penetrance. But for most sequence variations, we still do not know the significance. Unfortunately, large number of sequence variations in cardiomyopathies and arrhythmic disorders, there's limited data. We have to follow the ACCG guidelines in trying to identify the sequence variations. Despite that, a majority of them will still be of uncertain significance. And we must remember that the classification can change over a period of time. That means today what we classify as uncertain significance, after maybe a year or two, as more data comes in, the label can change. So are mutations in India any different? This is a very important topic because there is limited data in Indians, and we cannot rely on the Western literature to find out the significance of the sequence variations. And if we look at all published data, this is what we analyzed. We analyzed all the published data from till 2020. That means every single sequence variation which is reported in Indian cardiomyopathy patients since it was first reported in 2000 till 2020. What was seen was that over 1/3 of all sequence variations were novel to Indians. That means these sequence variations were not reported in Indians. So all I have tried to do is to just highlight the importance of genotyping in carrying out cardiac autopsies to help the relatives. This is where really the relatives can be helped. Identification of mutation is important for family screening. Sudden cardiac death may be the first presentation in asymptomatic individuals. Even asymptomatic individuals are at disease with disease are at risk for sudden death and should be risk stratified. And this is where the role of the autopsy of genotyping during autopsy comes in. Thank you. Back to Dr. Uma, please.
Thank you, Dr. Ajay. That was very crisp and short. But I think all the pathology residents who are listening to us probably would get an overview why molecular autopsy is required. So what autopsy can teach us and what are the gains from autopsy, not only for the deceased, but for the family also. So to continue with the talk further.
Actually, I just wanted to highlight the clinical aspect that we have to look at what is going to benefit the family from the autopsy. Yeah. And apart from a diagnosis, getting the mutation is extremely important.
Yeah, I would be talking in the end a little bit about that. Just one slide. So now let's move on to the
Uma,
yes,
would you like to take some of the questions now?
Yes, ma'am. It would be nice.
In the chat box. I don't know what your because many of these are to do with the heart.
Yes, ma'am.
Now you're going to the respiratory system, aren't you?
Yes, ma'am.
All right. So maybe
Yes,
somebody can, Nisha or somebody can read the questions, please.
Yeah, sure.
Yeah. Yes, ma'am. There's one question from Dr. Hiral Shah. He wants to know how to differentiate acute MI and acute myocarditis as neutrophils are present in between myocardial fibers in both the conditions.
So, Dr. Hiral, I specifically highlighted that mostly in myocarditis, it is the lymphocytic infiltrate because myocarditis is mostly caused by viral infection, post-viral. However, there are only two types of myocarditis. When you have neutrophilic infiltration, that is infection associated, which could be bacterial or it could be fungal. But there you will find some bacterial colonies or fungal thrombi or fungal colonies in the myocardium. The other situation is when you have eosinophil-rich infiltrate, which is an altogether different situation, which occurs in hypereosinophilic syndromes or Loftus syndromes. In myocardial infarction, you get neutrophils accompanied with macrophages depending on the duration of myocardial infarction. Whereas in myocarditis, it is 99% of the times, I would not say 99, but yes, more than 95% of the times it is lymphocytic infiltrate. Sometimes may be accompanied with histiocytes or some plasma cells, right?
Okay, thank you, ma'am.
And of course, you have to examine the coronaries and see whether it is territorial, it is focal, or it is diffuse in nature. Okay.
Yes, ma'am. Dr. Babita wants to know how to differentiate old and new fibrin in HE slides.
Yeah, so that's actually a tricky one. Usually it is difficult, but the fresh fibrin has much more, lines of Zans could be seen something, much more granular appearance, I would say. Little old fibrin gets compact. That's the only way you can differentiate, but it's a very difficult one. You need to do special stains to identify whether it is fresh or old. But this is a soft clue which I'm giving you. Fresh fibrin is very, very soft and separated by each other. Whereas the old one tried to get compact because it's been there for a little while.
Okay. Uma, can I just add to that?
Sure, ma'am. Sure.
When you get fresh fibrin, it is reticulated. It's almost like a network that you see. If you look carefully, there is a reticulation. As the fibrin ages, it's true what Uma says, it becomes compact. It just becomes like a sheet. Whereas it is fine and reticulated with like a network, like a fishnet, when you see it on H&E. Huh? That's what I'm saying.
I'll be showing some cases when I'll show respiratory system cases.
Okay, good.
Yes, ma'am.
And one more question.
Yeah.
Dr. Meeta wants to know, in sudden death, how do you determine prior to autopsy whether it's an accidental death, homicide, or suicide? How do you determine whether it's a pathologist or a forensic expert who's going to perform the autopsy in case of sudden death?
Yeah. So see, if the family members are getting the patient, right? Mostly. Sudden deaths usually occurred mostly early mornings, either in the bathtub or in the bed while asleep. So that is mostly non-forensic. When there is a foul play, it happens in young females. Many a times it happens in our situations also. A pregnant female found dead suddenly. Then it becomes medical leave. So you have to be very careful at that time. And it is the medical examiner, the treating physician at the first point of contact is most important. You will get the autopsy depending on the history which is being provided to you. So as I said, most of the sudden cardiac deaths or sudden deaths, when occurring at home without any suspicion and the medical examination shows no foul play or the history also suggests no foul play, it is medical, whereas the other one becomes medical. Okay.
Yes, ma'am.
Yeah.
One more question, ma'am, from Dr. Karthikeyan. He's asking, ma'am, from which area of heart SA node and AV node section should be taken?
Well, that's altogether a big topic. So if maybe next time when I talk about cardiac dissection, I can show that video. So that's really a tricky one, and you really need to hold the heart to know how the section is being taken. But I can demonstrate it in one of the next sessions when I talk about cardiac dissection. Okay.
Thank you, ma'am. Thank you.
Yeah. Okay. So after sudden cardiac death, the next sudden death syndrome can be secondary to respiratory system involvement. And very commonly, the cause is acute pulmonary thromboembolism. And it is usually occurs as a complication of deep venous thrombosis. Whereas, however, I have seen patients as young as 40s or even 30s presenting with thromboembolism with no history of deep venous thrombosis. And sorry to share this, I lost one of my old students who was just 30 years old with pulmonary thromboembolism, right? So you have to be, it's a tricky situation because you will not suspect thromboembolism in such patients. But that resident of mine had a history of pulmonary tuberculosis long back. Possibly there was some damage to the artery at that time. There was some element of arteritis secondary to TB, which might have aggravated the thromboembolic phenomenon. So we have seen pulmonary thromboembolism too much in SARS-CoV-2 infection, right? So post-COVID, patients who have recovered from COVID, they have shown humongous amount of thromboembolic phenomenon, not only in respiratory system, also involving the other system. The commonest presentation being severe pleuritic chest pain. And the closest differential diagnosis is myocardial infarction, right? Or pulmonary infarction. And it is fulminant in around 90% of cases, right? If the timely diagnosis is not made and timely intervention is not done. The other symptoms may include symptoms related to the ARDS. Sometimes patient may have some fever syndrome with or without pseudo-pneumonic symptoms, right? Yeah. Okay. So as I said, yeah, what are the causes? Respiratory causes. So which can lead on to sudden death. So there could be massive hemoptysis, which could be secondary to tuberculosis, bronchiectasis, abscesses, mycetomas, and even lung cancers. Severe pneumonia, which happened in SARS-CoV-2 pandemic, causing ARDS, secondary to viral or bacterial agents. Fatal asthma attack. Usually, my experience, I was fortunate to do a house job in medicine and cardiology. The asthma patients usually survive much better, although it could trigger a heart disease and can cause sudden death, right? Anaphylaxis, we all know, can trigger sudden death, especially due to respiratory causes, and bronchospasm. That's a very, very important airway obstruction due to anything. Aspiration, foreign body, edema, angioedema is a very, very important cause for sudden death due to respiratory system. Large airway obstruction, and these things are much more common in children less than 3 years old. So we know that there is a myriad of symptoms in sudden death due to respiratory cause, and which may present as acute right heart failure, shock or hypertension. They could be presence of pulmonary congestion and may present as left heart failure, and chest pain is similar to pleuritic syndrome or like acute myocardial infarction. It may be associated with hemoptysis or effusion, or may be associated with occasionally syncope. There could be a history of DVT, which may cause silent PE and causing severe chest pain. And then you may have occasionally abdominal pain without acute abdomen or a delirium state, right? Now, let me show you some of the cases. Now, this is a 63-year-old male. The patient had a clinical diagnosis of type 2 DM and patient was post-COVID. And the clinicians also thought that there was ARDS post-COVID. Not going, yeah. And also acquired pneumonia secondary to the hospital stay with query pulmonary thromboembolism. This is how the lungs look like in fresh state. This is a tracheobronchial tree, and this is viewed from the posteriorly. The rings are on the anterior surface. Part of thyroid is there. You see there's some erosions and congestion in the tracheobronchial tree. The lungs appear diffusely hemorrhagic, whereas if you examine the pulmonary artery at the hilum, they contain something. This is the pulmonary artery on the left side. Why it is left side? Usually we say that the bronchi, the segment of the bronchus on the left side is long. L for long, left long. So this is the left pulmonary artery which contains the thrombus, and it has been dissected till the pleural surface, and it contains the thrombus till here. You can examine here. And this is the closer loop. If you see some erosions in the trachea, possibly secondary to the intubation, also in the left bronchus, and a pulmonary thrombus right sitting in this pulmonary artery, and secondary to that you are having diffuse pulmonary hemorrhages. Yeah, one more thing, if you see the right pulmonary artery also contains a thrombus, right? And this is what the lung showed microscopically. So what you see is a hyaline membrane deposition. So right eosinophilic material deposition around the alveolus septum. So there is no doubt that there is presence of ARDS, right? In addition, yeah, this is a higher magnification to appreciate this hyaline membrane, which is brightly pink positive on PA stain, not significant inflammation in the alveolar spaces. And of course, the section from the pulmonary artery showed this fresh fibrin thrombus. Now, as Dr. Borges was highlighting, that it looks more fibrillar and fine. This is fresh fibrin thrombus, right? And it mixed with neutrophils. And from the right side also, it showed thrombus in the pulmonary artery. Now, this is relatively old fibrin, so it is becoming a little more compact. So these are the branches of pulmonary artery. Focally, there was organization of the thrombus as well. So this is the wall of the artery, and this is the organized part of the thrombus, and this is the thrombus. So this patient died secondary to the PTE, which occurred in conjunction with ARDS, right, post-COVID. Now, in the heart, this patient also had heart which was overweight, weighed around 420 grams. The shape was essentially maintained. And this is the inflow tract, where myocardium showed this amount of discoloration, little bit of discoloration, some pale areas there. This is the outflow tract of the left side. The aorta is there. Coronary sinus. This is the right coronary sinus, and here lies the left coronary sinus. And you have some amount of discoloration just next to the epicardial surface. And the concentric cross-section view of the myocard, the heart, is the left ventricle, the right ventricle, some thrombus present in the right ventricle cavity, and you have these pale areas which are seen transmurally right here, and some pinpoint hemorrhage is also seen along with that. So these pale areas represent scar formation in this patient, and this is how the microscopy looked like. So the sections taken from those hemorrhagic discolored areas showed evidence of this inflammatory infiltrate. Now someone asked me a question about myocarditis versus myocardial infarction. Now you see here, the fibers are retaining their nuclei. They are not hypereosinophilic, they are not wavy. So by wavy, you know sea waves. Most of you are probably from Mumbai, so you know how the sea waves look like. Everyone knows actually. In addition, there is interstitial edema, but there is no congestion or hemorrhage. So this qualifies for myocarditis. So there was evidence of myocarditis in this patient, and this section is from the congested areas, right? In addition, there was evidence of old hill myocardial infarction, the scarred area which I showed. So there was presence of diffuse alveolar damage in the early fibrotic phase with severe pulmonary thromboembolism involving both sides, focal myocarditis, which is post-viral. In addition, patient also had disseminated CMV infection in the lungs adrenal, which I have not shown, and with triple vessel coronary artery disease, diabetic nephropathy, and old age MI in the LAD territory. Now let's see this another case, which was 58-year-old male, again post-COVID ARDS, right? We had a lot of mortalities post-COVID. So the long COVID is still ongoing, and clinically they were suspecting DIC. There was some evidence of pleural effusion. If you see, this is lungs viewed from anterior surface. I showed the posterior surface in the previous case. This is from the anterior surface. The pleura is essentially normal, it's slightly lusterless. This is the drying artifact. Okay. So don't take this as a pathology. So what happens if the organs are not dipped in formalin properly? This is what happens. Some evidence of pleuritis is seen more so on the right upper lobe, right? Okay. And this is on the cut surface. So if you see the cut surface, you have areas of consolidation, more so in the lower lobes. Some patchy pleuritis is there. See here. And you have this hemorrhagic lesion here. And thrombus in the pulmonary artery can also be seen here. So this is also seen on the right side. This is not the left side. This is the left side, and you have some mucosal folds. So sometimes chronic bronchitis is there. Patient might be a smoker, which may cause this kind of loosening of the mucosa or folds in the mucosa. And this is what the lung looks like. So you have fibrin, you have some adenomatoid change, or you can say type 2 pneumocyte proliferation in the lung, and lot of hyaline membrane formation. You see here. So this is the MSB stain, which is highlighting the hyaline membrane containing fibrin. The PA stain, again showing PS positive hyaline membrane. And focally, it was showing organization in the form of this Mason's body and some evidence of interstitial inflammation. Normally, you should not see a single inflammatory cells in the interstitial septate. So there is presence of lymphocytic infiltrate. If you see interstitial infiltrate in the lung, that suggests a viral infection. And very occasionally, CMV inclusion could also be seen in the alveolar epithelial cells with moderate degree of interstitial infiltrate. And this is on oil immersion, right? So you have the inclusion, nuclear inclusion surrounded by hair. The vessels showed recanalizing thrombi. You see here multiple lumens in the artery and highlighted on the elastic stain. And of course, there was fresh fibrin thrombi present as well. Now, the COVID RT-PCR was negative from the lung tissue. However, the serum preserved at the time of autopsy did show reactive COVID. Now, as far as we were concerned, this patient was COVID negative because he was treated for COVID and it was almost 3 weeks post-COVID. But the serum sample collected at the time of autopsy was reactive. And the lungs and tracheobronchial tree had diffuse ulceration erosions with squamous metaplasia. There was diffuse alveolar damage in the fibrotic phase of more than 20 days, along with chronic thrombotic vasculopathy and pulmonary thromboembolism, right? In addition, there was evidence of bronchopneumonia, which happens in most of the patients who undergo autopsy. And so this was the final diagnosis in this patient. So there was DAD, with superadded bronchopneumonia with occasional CM inclusion, arterial and complicated atherosclerosis of the aorta with left ventricular hypertrophy. Now let's see this case. So if you see the series of cases, most of the cases are in young adult age group, right? But for maybe one or two who are 50 plus or 60 plus. Again, 41-year-old male. This patient was a known case of chondrosarcoma. I think by now the cause might have hit you. You know, the cause is written here. So this patient died post-operatively on day 4. And this is what the tumor looked like. Antemortem. You can see this mandible ka part. The tooth can be seen here, and this is the tumor. So it was diagnosed as chondrosarcoma. The lungs, as seen from the posterior aspect, very lusterless pleura and some fine fibrin threads here and there. And the cut surface of the lung showing this thrombus present in both sides, right? In the branches of the pulmonary artery. See here, an organized fibrin thrombus present here on both sides, and this is how the thrombus look like. This is the wall of the pulmonary artery and the lumen containing this fresh fibrin thrombus, very fibrillar, finely granular. As madam was saying, reticulate appearance, right? It's not compact. And this is on the marshy scarlet blue stain, which highlights the fresh fibrin red in color. So there was presence of pulmonary thromboembolism on both sides, see here, even involving the major pulmonary artery. So it was a case of saddle thrombus. And if you see the section, this is the respiratory lining. This section has been taken from the hilum region. So branch of pulmonary artery, fresh fibrin thrombi on either side. So this was a case of bilateral massive pulmonary thromboembolism of the pulmonary artery. Now let's see the heart. How the heart looked like in this patient. The shape is maintained. This is the normal shape of the heart. And this is what we call as bread loafing of the heart, from apex till the base of the heart. Now we know that there are two bases of the heart. One is the anatomical base, which is resting on the body, and this is the surgical base, the AV group, right? This is called a surgical base because most of the surgeries are performed through right auricle, right? And this is the approach. So if you see this cross section or the bread loafing method, you have these small discolored areas in the myocardium. You see here some discolored areas, hemorrhagic, linear discolored areas could be seen involving the posterior wall and the septae. And when we examine, whenever you see such an area, you have to see the coronaries very diligently. So the RCA shows luminal occlusion after nearly 2 centimeters from the surgeon, and so the LAD also showing narrowing. And this is the left ventricle, which shows significant hypertrophy with areas of scarring in between as represented by these pale areas. And this is what the arteries look like. So this is the RCA, again showing almost 50 to 60% narrowing, and the LAD showing almost 70% narrowing. And the myocardium mostly show old healed MI. You see here, this is what is replacement fibrosis. These are the preserved myocardium, and this is the replaced fibrosis. Another area to appreciate this replacement fibrosis in the myocardium, one focus showed these waviness of the fibers. However, it was not qualified for the acute myocardial infarction because the area was very focused. This patient had double vessel coronary artery disease involving the LAD and RCA with old healed myocardial infarction involving the left anterolateral wall. And one small focus of acute MI. Now let's see another case. The lungs are pretty heavy. You see 1472 grams. Normally the lung weight is not more than 600 to 700 grams because lung is full of air. So it's not containing any solid area, just for the alveolus septae. Most of the weight is because of the tracheobronchial tree. And this is the cut surface of the lung. The lungs appear diffusely hemorrhagically consolidated, right? This is the posterior surface. If you see again, fine fibrin threads are there on the pleural surface, subpleural. But some nodular projections are there, which were better felt than seen. See here? Another cut surface which shows diffuse pulmonary congested areas with causing hemorrhagic consolidation. And in addition, there was these nodular areas which were present predominantly in the subpleural location and causing this kind of wedge-shaped infarct. And next to that, we could also see thrombus in the smaller pulmonary artery. This is another infarct in the upper lobe, hemorrhagic infarct with thrombus in the branch of the pulmonary artery. And this is the opposite side again. So this was very, very firm to nodular inferior. And this is what the section looked like. So if you see the low part, you have these vessels which are occluded with something, and you have this hemorrhagic infarct, which was very, very firm to feel. This is another part of the vessel which is occluded. And this is the high magnification showed. The vessels were occluded with this fungal hyphae, right? Containing lots of neutrophils, and they were causing angioinvasion. Another photograph appreciating this angioinvasion, fibrin, neutrophils, and vasculitis. So there was fungal vasculitis, and this is on further higher magnification to appreciate the morphology of fungus, which was broad aseptate folded fungal hyphae, which was present within the lumen, causing angioinvasion as well as fungal thrombi. So fungal thrombi usually causes subpleural infarcts. Mind you that they're very firm to nodular to feel. They sometimes so firm to feel that they break apart. You know, when you cut them, the thrombus comes out. So this was angioinvasive fungal infection. In addition, this patient also had left heart failure, as evidenced by collection of these macrophages, pigment laden, which was all stained by pearl stain as blue in color. Okay. So there was bilateral pulmonary mucormycosis with infarctions. Secondary to that, there was alveolar hemorrhages. There was, in addition, evidence of myocarditis and portal carditis in this patient, and this infection association caused secondary hemophagocytosis along with superadded esophageal candidiasis and acute tubular injury. Let's see another case. So this is a 50-year-old male. This patient was a known case of acute promyelocytic leukemia. So patient is high risk, right? And patient had sepsis with acute tubular necrosis and history of acute CVA. This is how the lung looked like. Again, the lungs are showing you diffusely hemorrhagic consolidation. None of the lung parenchyma was preserved. There was no air. And this is what the microscopy looked like. Okay. And on a closer examination, you can also see fresh fibrin within the alveolar spaces and lots of neutrophils. So this patient had alveolar hemorrhages and was going into ARDS because there was organization of the fibrin and presence of fibrin within the alveoli. And in addition, because there was so much of hemorrhage and some of the hemorrhages were very firm, this is what we saw. So another vessels which is totally occluded by fungus. So multiple, right? And if you see on a closer look, these are fungal profiles which have acute angle branching, septate acute angle branching, and again causing angioinvasion. So this patient had DAD along with fungal infection as invasive pulmonary aspergillosis along with DAD in exudative phase. And patient also had residual leukemia in the bone marrow. In addition, because of the septicemia, patient had DIC in the kidney and brain and leukostasis in the lungs, kidney, and brain. Now, let me take you to the journey of this another young male, 45-year-old. Now, probably you might be noting that all the patients are in the age bracket of 40 to 50. And 40 is the new 20, I guess, right? And 50 is the new 30 these days, right? So I'm the new 30. Okay. So this patient had 1 week history of dyspnea and 2 days history of frank hemoptysis. The urine analysis was positive for blood and protein. So by now, probably the bell must be ringing. There is proteinuria, there is hematuria. So there has to be something related to that. The HRCT showed bilateral lower zone consolidation. You see here, both the lower lobes. And the clinical diagnosis was just pulmonary hemorrhage. They were not sure what it is causing, whether there was a rupture of pulmonary artery or there was pulmonary thromboembolism or what was the cause. And this is what the lung looked like. You see, diffuse pulmonary hemorrhages. But the difference between the one which I showed was not having any intervening normal parenchyma. This is the intervening normal parenchyma with lot of hemorrhagic areas in between. And this was not very firm to feel. So this was not really thrombotic. And this is what it looked like on high power. So diffuse alveolar hemorrhages, but the septa also showing some cells. And this is a low power. You can see that there is presence of hyaline membrane. The capillaries in the septa shows a lot of nuclear debris and leukocytoclasia. So that means there is alveolar capillaritis and alveolar hemorrhage. And this is I'm sorry about the pixelation of the picture. This picture has been shared to me by my colleague, Dr. Amanjeet. So this is how I got it. So it's slightly pixelated. So they were all nuclear debris and neutrophils, which were present in the capillaries, destroying the capillaries. So there was capillaritis, which was causing alveolar hemorrhages. And in addition, there was evidence of ARDS. So this was a case of microscopic polyangiitis with capillaritis and diffuse alveolar hemorrhage, right? And we lost the patient suddenly. As I said, there was a history of hemoptysis and suddenly he collapsed. Now let me show you another example. Again, 40-year-old male. And I don't know, somehow I'm also noting that most of the patients are in the bracket of 40 to 50. This patient had gradual increase in shortness of breath on exertion. He also had mucoid expectoration with streaky hemolysis. There was dark-colored urine. CT scan showed diffuse alveolar shadows, and clinical diagnosis was renopulmonary syndrome. And of course, there was a suspicion of vasculitis. So if you see these lungs appear little rubbery. They are not diffusely hemorrhagic. Compared to the ones which I showed earlier, there is no significant thrombus in the pulmonary artery. You see here, there is a hilum. The tracheobronchial tree also essentially looks normal with some erosions, right? And this is what the lung looks like. Diffuse alveolar hemorrhages. And again in the alveoli, you have this capillary proliferation. So what does it show? Again, you have capillaritis. So if you see capillaritis in a lung section, please rule out vasculitis. That's the dictum, rule of thumb. Either it's microscopic polyangiitis, or it could be granulomatous polyangiitis, or it could be Church-Strauss or anything. And it is accompanied by diffuse alveolar hemorrhages. And of course, what we expected in the kidneys, there was crescentic glomerulonephritis. You see here, these are the crescents, which are mostly fibrous cellular. And of course, we performed the immunofluorescence, which shows linear deposition in the glomerular basement membrane and subsubendothelial deposits. So this was a case of good posture syndrome with diffuse pulmonary hemorrhage and crescentic anti-GBM glomerulonephritis. Now, this deals with the respiratory system. So I'm open to the questions related to the respiratory system before we move on to the last system, that is the CNS. But the most important. Any questions or any comments?
There is a question from Dr. Meeta Shah. I think this question is out of curiosity. She wants to know, ma'am, have you come across any case where you, as a pathologist, did an autopsy and then came across findings suggesting any foul play?
Wow. Yes, I have. So it was a young female. Let me share that case. When I was a young faculty, and we did the autopsy because at that time we did not think that it was medical legal. And after we doing the autopsy, we found thrombosis in the coronary arteries. And of course, we tried to label it as Kawasaki disease. But later on, we realized that patient was given something, and we found thrombosis elsewhere also. So it was later converted to medical legal case rather than a medical autopsy. It does happen. So situations like this, you need to handle very cautiously. Okay.
Okay.
Yeah. So moving on to the next important system, that is the central nervous system. Now, we all know that stroke represents the first cause of sudden death in all cerebrovascular diseases. And intracerebral hemorrhages secondary to hypertension is the cause of death due to cerebrovascular diseases. The most important risk factor being hypertension in non-traumatic ICH, and brain infarction is seen secondary to atherosclerosis or due to embolism as well. Sometimes there is imbalance of autonomic nervous system and loss of control is there over the cardiovascular system, which can also lead on to sudden death due to central nervous system causes. The two major categories due to brain damage in stroke patients include ischemia or hemorrhage. Now we know ischemia when there is lack of blood flow and there is no fuel or oxygen. Hemorrhage we know when there is a release of blood. Usually hemorrhage occurs secondary to the venous involvement and ischemia due to arterial. And ischemia further can be classified secondary to thrombosis, embolism, or decreased systemic perfusion. If we classify infarcts, so according to the types, so they could be pale infarcts or red infarcts. So we call the pale infarcts as anemic and red infarcts as hemorrhage. And of course, you have to classify the infarcts according to their sites, whether it's cortical, laminar, subcortical, white matter, basic ganglia, whatever. Because white matter infarcts usually are secondary to hypertension. So that's the importance of classifying from the site. Now let's see the stroke types. I'll share some of the examples. Clinically, stroke can be classified as TIA or evolving stroke or completed stroke, right? Now, completed stroke, you cannot do anything. TIA, you can reverse. Evolving stroke, also once it has occurred, probably you cannot do anything. It will lead on to cystic infarct later. But pathologically, you classify them focal or global. Ischemic secondary to embolic, thrombotic or hemorrhagic, and venous infarct. Now, venous infarct mostly occurs in young and mostly secondary related to the infections. Now, this is one such infarct on the right side. These are both the lateral ventricles. They're all dilated because there is a huge infarct, so it's called hemorrhagic infarcts. These both are hemorrhagic infarcts and they are both hypertensive bleeds. The bleed is also extending into the ventricles in this picture, and there is a shift to the left. You see here, there's a shift to the left, and the surrounding parenchyma also is congested. So, and they are close to the thalami. So, this is a classical case of stroke or hypertensive bleed involving the putamen thalami, involving the ventricular lining, and here even extending into the ventricle. Now, another important thing is you should know the watershed areas. Now, the watershed areas are areas where you have blood supply by two arteries. You have blood supply here by the anterior cerebral as well as by intracerebral. So this is the, in between area, line of control. So Pakistan is saying it's us and India is saying it's us, right? So it's Pakistan occupied Kashmir. So they are called as watershed infarcts, right? So this is the area where you should look for. These are not the infarct, but on this side, if you see, there is a softening. So this is the watershed infarct, okay, where there's a wedge-shaped softening in the left side. When you see cerebral infarction, how will the microscopy confirm that this is infarcted? Very early infarction, we call it, it looks like red angry neurons. Why red angry? Because the cytoplasm looks much more pink and the nucleus is also very pyknotic. More than 24 hours, you will have neutrophilic infiltrate, and more than 72 hours, you will have some evidence of gliosis at the periphery along with macrophage. You have to do a myelin stain to demonstrate loss of myelin. And of course, you will have sometimes profuse gliosis when the infarct is of little duration. Okay. Another panel of pictures to appreciate the infarcts. This is the one-day infarct. You see this red angry neurons. They're looking very bright red color, pyknotic nucleus. This is in 3 days when you have lots of neutrophils. 1 week, macrophages have started accumulating. And this is more than 3 weeks, which is becoming cystic. So these pale areas are the cyst formation. And if you see this is an infarct which is more than 3 days, right? So you have this brownish discoloration, and this is in the area of watershed area again. And this is more than 3 weeks. So it's becoming cystic, right? So these are called as cystic infarcts. Now, again, to show this red neurons, red angry neurons, nuclear debris and polymorphs, forming macrophages, you all know, and of course, mononuclear cells. Now, this is a section taken from the cerebellum. Normally, the Purkinje cells will not look like this. Normally, it will have a look like this, something like ganglion cells. But this is a angry Purkinje cells because it is having hypoxia. So it's showing you hypoxic changes. Now, let me share this case with you. Here, the brain weight 1460 grams, slightly overweight. The sulci and gyri are essentially normal, but there is congestion of the meningeal vessels. However, when we examine the base of the brain, this is the circle of Willis, this is a vertebral artery and branches of ventral cataract. They all look discolored. So, and they felt cord-like, right? And this is the optic chiasma. You can see here, olfactory bulb, and you have herniation. You see this truncal herniation, swollen gut. So, this patient had enough evidence to cause sudden death, enough etiology to have sudden death. This is the dissected of circle of Willis, the vertebral artery here, and all the vessels showed thrombosis. You see here? So sampled from here as well as here, both of them showed presence of this fresh fibrin thrombus. Another section from the posterior cerebral artery and the middle cerebral artery also showed presence of thrombus here. So this patient had multiple thrombi in the circle of Willis, which caused infarction. Now let's see the brain slices. You see here, there's an infarct which is involving frontal region. You see areas of discoloration, softening around, and as we are going posteriorly, it is increasing. So surrounding brain parenchyma is also showing hemorrhagic discoloration. However, more posteriorly, it was normal. And this is what the microscopy looked like. So you had this infarct with neutrophilic infiltration. So high part to show the neutrophils, so which suggests that this infarct is of more than 24-hour duration. In addition, there is diffuse microcystic change, right? You see here at the periphery of this infarct. And some of the areas also showed involvement, entrapment of these vessels with some macrophages in the vicinity. You see here, these macrophages highlighted by CD163. The other stain which you can do is CD68 for the macrophages. So this tells you that the infarct duration is maybe from 3 days to around 1 week, right? However, there was another pale area which was appreciated and it showed no inflammation, no congestion, but there was profuse gliosis, and this is a GFAP stain to appreciate these astrocytes, star-shaped astrocytes. No, recently चांद पे आज आके आए हम, so हमें stars भी देख लेने चाहिए. So you have these star-shaped neurons, which tells you that there is gliosis. So this was an old infarct also present in this brain, so which was undergoing cystic change with surrounding gliosis. So there were fresh infarcts in the frontoparietal region, in the MCA territory, and in the thalamic region, and then there was an older infarct in the internal carotid MCA territory again, right, with presence of thrombus. Now the next cause of sudden death due to cerebrovascular causes, subarachnoid hemorrhage. Usually these hemorrhages occurs due to rupture of the berry aneurysm, and they constitute of around 5% of the stroke cases, right? Smoking, high blood pressure, and increase in age, and are also female sex, are independent risk factors of SAH, right? The other causes which can cause subarachnoid hemorrhage could be brachial meningitis, sometimes even tuberculosis when it causes arthritis, epilepsy, brain tumors. I'm not including trauma here because they will go to the medical legal side, right? And this is how the gross will look like. You see diffuse subarachnoid hemorrhage at the base of the brain, right? And this is a pontine hemorrhage. Old pattern. This is how it looks like in fixed state, and this is in the fresh state with lot of uncal herniation, right? So whenever there is uncal herniation, there is coning. So patient may not die of hemorrhage per se, but the edema and coning and herniation may cause death. You see the gyri, they're so swollen, and sulci are being narrowed because of this hemorrhage. Okay. Now let's move on to the miscellaneous or other causes which can lead on to sudden death. Though not very often and very common, but commonly we can have sudden death due to massive bleeding, which could be of very etiology. It could be duodenal or gastric ulcer. It could be malignancy, ruptured ectopic pregnancy, or maybe ruptured viscous from bowels, or sometimes ovarian cyst, acute liver failure, pancreatitis, or disseminated infections. And of course, do not forget vasculitis. Now, this is a 48-year-old female who had a history of hypercalcemia-induced pancreatitis, and patient was suspected to have right inferior parathyroid tumor with multiple complications. So externally, because there was a lot of ascites and there was hemorrhagic collection in the peritoneal cavity, multiple pigtails were put in her abdomen, and there was 1000 ml of yellowish fluid found in the serous cavity, that is peritoneal cavity. And this is how the pancreas looked like on gross examination. So it was a lumpy, soft, necrotic mass with a lot of fat necrosis around it and very, very foul smelling. And this is a closer look to appreciate this lumpy, soft, necrotic, foul smelling mass with a lot of fat necrosis. And this is how the low part looked like. No cellular details could be visualized. It is just necrosis. Nothing else could be seen. And on closer examination, we could also identify some vegetable matter. So possibly there might have been some injury while putting the pigtail, or there might have been some injury to the bowel wall, which has resulted in exudation of this vegetable matter. And very focally, we had areas of this grungy calcification, but no inflammatory cells. So this kind of things will not give you enough time. This kind of pancreatitis will not give you enough time to save the patient. They are fatal in 90% of cases, right? Especially when the pancreas is involved in toto. Here, the pancreas was involved up to 70%. The remaining pancreas was much more firm. You see here with dilatation of the duct. And this is what the microscopy looked like. A lot of fibrosis and inflammation, right? So both interlobar and intralobar. And of course, the ducts were also dilated with inspissated secretions and loculated fat necrosis. See here, bordered by this fibrosis. Okay. So this was the final diagnosis in this patient. So patient had autoimmune thyroiditis. There was hemorrhagic pancreatitis along with features of chronic pancreatitis, possibly autoimmune. I do not know. There was diffuse steatosis in the liver secondary to the malnutrition. Focal adrenalitis was there along with hemorrhages. And of course, patient had stones in the ureter and gallbladder along with ACN. And she died of pulmonary thromboembolism. So you see, at autopsy, in spite of so many other causes, patient also had thromboembolism. Okay. Now, sometimes you may not find a cause. That happens mostly when the cause of death is due to endocrine system. So before you say that the patient died of any endocrine cause, you have to rule out all other causes of sudden cardiac death or sudden death syndrome, right? Which includes diabetic coma, adrenal insufficiency, hypothyroidism, mixed coma, parathyroid crisis, and also thymoma with paraneoplastic syndrome. So I remember only one such case at autopsy. There's a section from the adrenals. You see diffuse hemorrhages in the periadrenal region, which is also seen in the interstitium of the adrenal. So you see here congestion as well as hemorrhages here, and a higher magnification to appreciate these RBCs with some macrophages and hemorrhages extending into the adrenal. So this hemorrhage was of some duration because there are macrophages seen. Finally, they will come eat up the RBCs. Party to mana nahi hai, there is so much hemorrhage going on. So someone has to come and clear that up. And of course, adrenal infarction. So you see interstitial hemorrhage in the adrenal along with adrenal infarction. So this was the cause of death in this patient, terminal. This happened terminal. This usually is not demonstrated unless until you do the autopsy. Now, of course, iatrogenic causes could be sudden withdrawal of steroids or any other drugs, and sometimes could be related to any untoward incidents, tragic events related to medical errors, maybe anesthesia related or mismatched blood transfusion, and surgical as well. Amongst the miscellaneous causes, it can be drug abuse or maybe errors in consumption, especially in the older people, or taking wrong medicines, or maybe hormonal and any other related cause, right? I have witnessed 2 cases of cocaine-related sudden deaths in my experience, and those patients had infective endocarditis too. They had significant weight loss and the heart showed features of dilated cardiomyopathy. However, sometimes they just die because of the fatal arrhythmias. So you should keep that also in mind before you label the patient as that, okay, no cause was found. So you should rule out that history also. That's very, very important. So the other miscellaneous causes of non-cardiac sudden death include anaphylaxis, bacteremic shocks, shock from the dread, fright emotion, which is vagal inhibition, sickle cell crisis, and alcoholism. Now that could still be unexplained even after the adequate postmortem investigation and exhaustive study. So you label that autopsy as indeterminate. That cause of death could not be determined. So it is indeterminate. So this represents a very critical situation and it has a very serious clinical implications both to the treating party as well as the patient party. So it leaves the family members at risk also because they do not know whether this is going to occur in next family member. So Dr. Ajay very beautifully highlighted that aspect. So we need to improve efforts to ascertain cause of death in sudden deaths, right? So a practical workflow has to be applied in every case of sudden death, and there comes the role of autopsy. So this is the practical workflow. So you have a sudden death, you do external examination, you do examine other medical records. You may find a cause of death at autopsy, you may not find, then you go for a molecular autopsy, toxicological investigations, and even postmortem imaging. Now, there are facilities these days in most of the mortuaries, autopsy centers, where you can have postmortem imaging. Not in India though, but I'm proud to say that we have a state-of-art autopsy center in our institute, which has this facility. And of course, you have to collect samples, including the heart, the splenic tissue for any molecular studies, and of course, FFP tissues for other things. And of course, don't forget PCR for any viral genome studies, right? So that's very, very important to rule out a specific cause of sudden death. So to summarize, coroner's postmortem is must in all sudden deaths. A forensic investigation may determine a cause of death approximately. However, 19% may remain unsolved, which requires further investigations. The autopsy report must include clinicopathological summary of the major positive findings and their relationship to the cause of death. A molecular autopsy is necessary, which may help to identify cause of death in these large percentage of unsolved cases. And an accurate diagnosis from a molecular autopsy will help in initiation of appropriate preemptive strategies, which may be helpful in preventing sudden death. And with these autopsy negative sudden deaths, there is an emerging role of medical examiner. So we have identification, we can do identification of new risk markers of sudden death, which remains one of the most important research fields for the scientific community. So identification of mutations of lethal inheritable cardiomyopathies or novel mutations and for various channelopathies that can be identified and which can be further applied in the prevention of sudden death in the family members. A multidisciplinary expert network is required to reduce unexplained deaths. A comprehensive multi-source surveillance STD registries is required, especially in a country like India where we do not have any registry for sudden death. So we have to work together, including the cardiologists, the forensic experts, pathologists, the intensive care specialists, genetists, molecular biologists, and toxicologists to ascertain the cause of death in these patients and help the families and the community further. So in the last, I would say it's a mammoth task. However, we have to take up this task and do it effectively and precisely. And simultaneously, I would also say that it's ferocious enough to take away the patients from us in fraction of seconds. So I must say in the end that education must award self-confidence, which gives us the courage to depend on one's own strength. So hopefully I have done justice to the topic given to me. I know I have taken almost 2 hours, but it was required because this topic has never been dealt in detail like this earlier at any forums. So thank you so much once again, Dr. Sumit and Madam Borges and all the audience who are present here tonight with me to listen to me. I'm open to any comments or questions. By the way, this painting is made by me. Hello?
Yes, ma'am.
Yeah.
There is one question, ma'am. Pathological autopsies numbers have reduced worldwide. Should pathology autopsy be a part of pathology curriculum in the years to come?
Actually, I would say we do not do coroner's autopsy. We only do medical autopsies. So that's what I said. Coroner's autopsies are must now. Because as Dr. Ajay very well highlighted, most of the times we have found novel mutations. We do not even have cohort of our patients. We do not know what is the important cause of sudden death in our group of patients. As I showed you, spectrum of diseases, starting from cardiac to respiratory to central nervous system. So it needs to be made a part of curriculum, either in pathology or we have a special course to special trained physicians to perform coronary autopsies. Right. And in PGI, fortunately, the autopsy numbers is still maintained. Our clinicians are very proactive, which includes Dr. Ajay also. I could show so many cardiac cases just because we have received autopsies from the cardiology department. Our emergency medicine department is very, very aggressive, and so is our respiratory, the pulmonology department. So if they are not able to ascertain cause in any patient, they would send an autopsy, or sometimes it could be because for the teaching only. So autopsy is a very, very good teaching modality for all of us.
Thank you.
It's an excellent tool, I would say. Any questions or comments, Ma'am Borges?
And there are no more questions, but there are comments regarding the talk. It's a difficult topic which has been simplified. In fact, blessed with such type of talks, excellent images, especially the gross images, ma'am, and brilliant cases.
Thank you.
Thank you, ma'am. Thank you very much.
Is Dr. Sumit around or left or what? Or Madam Borges is around?
We'll just.
It's okay. But I must thank all the participants who spared their time. Of course, I am also sitting here. See, for me, I'm teaching you all. But I have to have students to teach. I have to have listeners. Otherwise, this teaching is a full exercise is wastage, right? So I really thank each and every one of you who have patiently listened to me. I tried to simplify it because I know that most of you probably have not done the autopsies or have not seen the gross organs like this. But at least I would probably the images would stay in your mind because pictorial image stays for longer time. compared to the text. So I kept the text minimal. So I tried to teach you with images mostly.
Ma'am, there's one more question. How effective can one differentiate antemortem from postmortem histopathological changes?
Sorry, I didn't get the question. Antemortem from postmortem changes. In the
Yes.
sense, like what kind of changes she or he is wanting to ask? I didn't get the question.
To differentiate. I think he wants to know the infactoid changes, if there are infarction, if they are, can we differentiate? Is it antemortem or postmortem?
Postmortem, there is no infarction. Infarction will occur when the patient is alive. Either there will be thrombosis, or there will be embolism, or there will be ischemia in any organ, irrespective of the organ. So that is not going to occur when the blood flow stops. The blood flow stops, the ECG stops. There's a flat line. So it has to occur antemortem. It cannot occur postmortem. Yes, had the question be that how do we differentiate contraction band necrosis from the myonecrosis? Sometimes that can be a difficult thing. Whether it's a contraction band necrosis in the myocardium or it is just artifactual. So clumping of the contraction band, it becomes, but no waviness or no hypereosinophilia tells you that it's contraction band necrosis, and that happens when the death occurs in systole. Death can occur in diastole also. It can occur in systole or in diastole, or maybe there would be neutral stage. So you have to be vigilant enough to know that these are contraction band necrosis and not changes happening secondary to the myocardial infarction. Okay.
They are saying it is about hemorrhage or postmortem clots.
Okay. So postmortem clots usually will not have fibrin, right? So
Yes.
hemorrhage, when you say it has to be outside the vessel, right? If it is inside the vessel, it is a clot, or maybe it is just a congestion. But hemorrhage, when you say it's outside the vessel. Okay.
All right, ma'am.
Yeah.
Ma'am, Gujral sir and Porges ma'am had to leave.
It's okay. No problems.
Thank you very much, ma'am.
Thank you, Nisha.
Thank you.
Thank you, ma'am.
Thank you,
Thank you,
Dr.
sir.
Ajay.